Good morning. Assalamualaikum warahmatullahi wabarakatuh. So, good morning to Dr. Min Huang. Dr. Min? Hey, where's Dr. Min? Oh, something happened. And Dr. Susal Nur Suhaili, good morning from Brunei. Good morning, Susal. Yeah. And here we have our guest also, Dr. Yohan from Palembang. Thank you, Dr. Yohan, for your coming. Yeah. Okay. Where Dr. Min Huang is just, I don't know, where is he? Yeah, we wait. So, everyone, good morning. May Allah bless all of us. To this morning, the residents now has a rotation in rhinology division. In the 5th weeks, we will present a contrastive learning about the orbital apex syndrome as the complication of the rhinosinusitis. And then for 30 to 40 minutes. And then after that, can I have the Zoom link? Oh, okay. Wait. Dear, could you share the Zoom, Dr. Min? Here.
Yes, doctor.
Yeah.
The link is already in chat room, doctor.
Oh, okay. Yeah. Good morning, Dr. Min.
Bikin aja.
Yeah.
Kita siapin for the week.
Yeah. Probably, yeah. Please find the Zoom link in the meeting chat, Dr. Min. Yeah. Thank you for your coming. And then share your valuable lectures to enlighten our understanding about the type 2 chronic rhinosinusitis, the bilateral type 2, and we call it usually as a CCAD, central compartment allergic disease. So before that, if don't mind, the residents will present a case, and before that they will present themselves, but through the video clip. Please, the team, you may share your video clip as your introduction.
Thank you very much, Dr. Dani, for your kind introductions. Good morning, Prof. Min Huang, and also the fellow doctors and also residents. Today, we are going to present ourselves first from the video. Please, Dr. Ria, the screen is yours.
Ayo kita maju, mari kita lakukan selalu. Go green! Jangan pantang nyerah, kita memang yang harus memulai. Go green! Go green! Go green! Demi masa depan, agar negeri kita kan selalu. Go green! Go green! Jaga bumi ini, kita harus bersihkan polusi. Go green! Tanami kebunmu dengan bunga atau tanaman yang baru. Bila habis mandi, jangan lupa matikan keran air. Bumi cuma satu, disinilah rumahku juga rumahmu. Ayo kawan-kawan, kita menjaga ciptaan ciptaan Tuhan. Go green, kita memang yang harus memulai. Go green, kita memang yang harus memulai. Go green, kita menjaga ciptaan Tuhan.
Okay, so that's the introduction video from us. So there's 5 of us from Rhinology Division. My name is Diarianti, and there is also the third class senior, Aris Rahmanda. Please, Dr. Aris. And then we have the 2B resident. There are Delia and Disa. And for our junior, we have the one and only our beloved junior, Dr. Yogi. So I hope you enjoy the video that we have shared, that we have to try to go green to reduce the pollutant and to protect our beloved Earth.
Yes, the video is so fantastic. I love it so much.
Yeah, thank you, Doctor. I'm glad you enjoy the video. The song is in Indonesia, but we have create the subtitle so you understand that we have to like go green, like that.
Okay, dear, thank you. That's a very nice video of you. Before you start your presentation, now you can start your presentation. I hope after that we can discuss the content of your case presentation to deepen your understanding about the cases. Okay, with the help of Dr. Min, Dr. Susal, and all the audience that coming to this Zoom meeting today. Please, Dian, you can start your presentation and the team.
Okay, good morning, Prof. Minh Hoang, Dr. Dani, and also our beloved teacher, and also the fellow residents. Today we are going to present the contrast learning of the orbital apex syndrome as the complication of rhinosinusitis. Actually, this is the patients that we've got from our rotations until now. So we are going to present this case. Okay, please, next slide here. Okay, Dr. Yogi, the time is yours to present the case. Please, Dr. Yogi.
Okay, thank you, Dr. Aris, for the opportunity. This is the first slide, the characteristic of the patient. There are 2 patients will be discussed. The first one was a male, 54-year-old, and the other one is a female, 38 years old. Both have some same comorbidity that are diabetes. For the male, has no trouble with his sleep, and the other hand, for the female patient had a disturbance on her sleep that she woke up 3 times to urinate, and both have no surgical intervention history before. And then this is the clinical photos of each patients. As we can see, both of them have same condition of ptosis on their right eye, but on the female patient had a lump in her medial eyesight. Next. This is the male patient present medical history. He got sudden pain in his right ear 4 months prior to admission, but gradually better without taking any medicine. And then 3 months prior to admission, he suddenly felt a severe pain in his right ear and got diagnosed with a chronic tubotympanic otitis media. 5 days prior to admission, he suddenly has a difficulty to open his right eye, no nasal complaints. He got referred to our hospital. And for the female patient, she got gradually swollen on her right eye, decreased visual acuity 1 month prior to admission, going to a local hospital ophthalmologist and referred to ENT. She got hospitalized because of the lethargy and low intake 10 days prior to admission, and 2 days prior to admission, she came to our OPD with a swollen and drastically worsened visual acuity. She had no complaints for her nasal too. Thank you. Now we will continue to Dr. Delia.
Okay, thank you, Dr. Yogi. This is the clinical profile of these two patients. The chief complaint of both patients was a problem with the right eye. From the first patient, he complained unable to elevate his right palpebra, while the second patient has complained of decreased vision and also pain in the right eye. Next, onset in the first patient was 5 days, while the second patient was 2 weeks prior to admissions. In the progressivity, they are both gradual. We also evaluate a quantitative score. This can be seen on the screen, but the both of this patient didn't have complaint of nasal discharge, nasal blockage, or loss of smell. For complaint of pain, the first patient has complaint of headache with a visual analog scale of 6, while the second patient has complaint of pain in the right eye with a visual analog scale of 7. The first patient had other complaints, including pain in the right ear, ptosis, and decreased vision since 5 days prior to admissions, while the second patient has complaint of swollen on the right eye. Okay, next. This is the nasal endoscopic examination of the first patients. From the right nostril, we can see there's a narrow nasal cavity, and no discharge in the middle meatal, and mucopollulant discharge was found at sphenoethmoidal recess. From the examination of the left side, no abnormalities were found. Next. Next is the nasoendoscopic examination on the second patients. From the right nostril was found narrow nasal cavity, and inferior turbinate had irregular surface. Middle meatal look polypoid, and there's no black eschar was seen. From the left nostril, as we can see, there's a crust in the inferior turbinate with the presence of a fungal element or like whitish hyphae, but there's no black eschar is visible, and mucopollulant secretion is visible. Okay, next.
I will continue. From the right eye examination of both patients, it was found that in the male patient, there is a decrease in visual acuity of 1/300 good perception, whereas in the female patient, there is no longer any light perception. In both of these patients, there are also decreased light reflex and disturbance in the eye movement in all directions on the right eye. And also in the male patient, ptosis was observed, and in the female patient, in addition to ptosis, there was the presence of edema and lumps with undulation on the right palpebra. From the examination of the left eye in both patients, a slight decrease in visual acuity was found, while the rest was within normal limit. From the laboratory examination, an increase in infection marker was found in both patients. However, the infection marker in the male patient was higher compared to the female patient. Meanwhile, the glycemic control index in the female patient was higher compared to the male patient. In the microbiology examination of the male patient, Pseudomonas aeruginosa was found from the tissue culture of the right sphenoid, and the female patient on the microbiology preparation of culture secretion from the right nasal cavity, Klebsiella pneumonia was detected. In the parasitology examination of the female patient left nasal cavity, colony of rhizopus were found that indicating mucormycosis.
Okay, continuing to Dr. Disa. So this is the other supporting examination that we have already performed this patient. As we could see here that the eosinophils from the both of the patient, as we see here that the eosinophils is still within normal limits, but also unfortunately we are not performing any IG examinations, skin prick test, dyes, and also the PSG for these patients, although the second patient have the problem with her sleep. Then next, this is the prenasal CT scan. This is for the first patients we could see here. Please play the video. Okay, pardon. Okay, pardon for the technical problems. Please wait a moment. So this is the first patient's CT scan. As we could see here, the frontal, the maxillary, anterethmoid, and also the posterior. We cannot see there's any opacification in this patient, the first patient. But we could see here that there's opacifications in the right sphenoid, as we could see here. There's only the opacifications in the right sphenoid only in this patient, the first patient. But compared to the first patient and the second patient, Mrs. Katy, please play the video. We could see here we could see at the first of the frontal, maxillary, ethmoid anterior, and also the left sphenoid. There's an opacification in this patient. And also there's an inflammatory extension to the medial side of the right orbita. And also there's that we could suggest that there's an inflammatory extension to the right orbital apex compared with both of this patient. Next slide, please. So the working diagnosis for these two patients, that the first patient we assessed with the right orbital apex syndrome, with the septic right cavernous sinus thrombosis, isolated right spinal sinusitis, and also for the other diagnosis, we assess the chronic tubular myocarditis medium. Both of those patients have the type 2 diabetes. But the first patient, because this is already an older age compared to the second patient, the patient also has hypertension and acute kidney injury with the differential diagnosis with the acute and chronic kidney disease. But for the second patient, the patient has the right orbital apex syndrome with orbital cellulitis due to the acute necrosis with abscess. But interestingly, that the second patient has she has the two kind of pathogen that infect in this patient. First, the patient in the right side, the patient has the bacterial rhinosinusitis with orbital complication, but in the other hand, in the left side, the patient has the acute fungal rhinosinusitis on the left side. Both of the patient has the same characteristic with type 2 diabetes. For the treatment itself, the patient that we perform the surgical debridement of both of the patients. We also give the empiric antibiotic, which we are give Bacillus sulbactam intravenously with 4 times 1,100 milligrams. And for the complication, we also consult the neurology, ophthalmology, intramedicine, especially endocrine and metabolic divisions. Compared to the other hand, in the first patient, the neurologic also give the heparin with 10,000 international units over 24 hours. And from the other hand, in the first patient, the patient also received the hydroxymethyl prednisolone from the ophthalmologist. But for the second patient, as we could see here, that there are also the infection from fungal infections, that the patient also received the itraconazole with the loading dose about 3 times 200 milligrams for 2 days, and then 200 milligrams daily, once daily for this patient. Next slide. So for the surgical surgery intervention, that the first patient we perform the emergency endoscopic splenectomy dextra with the transethmoidal approach and also the septoplasty. As we could see here at the previous CT scan, the patient has right septal deviation, so that we perform the septoplasty to make the access wider for this patient. But in the other hand, the second patient, the patient was performed emergency full functional endoscopic sinus surgery, and also debridement with the medial maxillotomy on the right side. And because the patient has the characteristic of the complication from the orbita, the ophthalmologist perform the right orbital excentrations. Next slide. Please, Dr. Diar.
Okay, I will continue. For the intraoperative finding, we found normal because we approached through the transethmoid approach for the right sphenoid sinus. We found normal mucosa on the right maxillary and also ethmoid sinus. However, a mucosal polypoid was found. Here is the maxilla. It is very clean. The anterior ethmoid is also clean, but we found like polypoid appearance on the posterior ethmoid and also in the sphenoid. Here, in the sphenoid. Meanwhile, for the second patient, in all of the sinus, we found mucosal polypoid on the maxillary ethmoid and also frontal sinus bilaterally. but we found like a grayish yellow coral shape on the left sphenoid sinus, as we can see in here. Here is the thing that we found on the left sphenoid sinus. However, on the right sphenoid sinus, there was no discharge nor polypoid appearance. It was clean. And during the surgery, the first patient has a bleeding of 150 milliliters, while the second patient also have the same bleeding. Therefore, it can be assumed that the second patient has less bleeding compared to the first patient. Although the bleeding, we found nothing like cadaveric appearance for the second patient. During follow-up, we found that the first patient had improved the ptosis. He could elevate partly his right eyes. However, there was no improvement in the visual acuity. He currently have no pain and no nasal discharge. The neurology and the ophthalmologist still continue the treatment for the heparinization and also the high-dose methylprednisolone. And meanwhile, for the second patient, the patient was discharged after 6 days post-operative. She currently had no pain and no nasal discharge, but still consumed the antifungal treatment once daily. And for both patients, we are still waiting for the histopathological result. In conclusion, the first patient, we have the pathogen of bacteria with the increasing sign of infections in the laboratory evaluation. Meanwhile, the second patient, we found pathogen fungal infection for the left side and bacterial on the right side. And both of them have the comorbidity of diabetes mellitus type 2. And we know that the second patient had higher glycemic index. The diabetes was uncontrolled. For the first patient, we only performed the surgery unilateral. Meanwhile, for the second patient, we performed it bilaterally for the debridement. The first patient also had the septic right, aside from the orbital apex syndrome, he had the septic right cavernous sinus thrombosis. We think this might be due to the inflammation and the surrounding area of the sphenoid sinus. And the second patient, she has a poor visual acuity and also severe pain. Therefore, the ophthalmologist decided to perform the orbital exenteration for the right eye. And the first patient is still hospitalized currently, and he still had received the heparinization and also high-dose steroids. That's all from us. Thank you.
Thank you, Dr. Diar and the team. Dr. Aris, the third year residents. Dr. Delia and Dr. Disa, the second year, the senior second year, and Dr. Yogi, the junior second year. Okay, so I give the opportunity to Dr. Min Huang to give comments or ask further question to the residents. Please, Dr. Min.
Thank you, Professor Danny, and thank you for the Indonesian resident team to present two cases with the same problem about the exacerbation and also the acute bacterial sinusitis, and also it looked like the invasive fungal sinusitis in some way about the mucormycosis. Actually, all of the residents have a very clear about the history, the clinical examination, the radiological finding, and also how do you deal with the case. And but to get the right answer for the second case, I mean for the lady that you do the of the acceleration, because when will you did the case, and so far you don't have the result from the biopsy. There are no no result. So I confused because if the second case they had the invasive fungal sinusitis, it will be you need to treat the patient with the right medication, because mucormycosis will be different from the you got the biopsy before the surgery. May I have the answer from the resident? Because you said on the screen like the patient got the mucormycosis, the second case.
Yeah, I think that's what we want to have for the residents to do the interaction with the foreign invited teaching faculty from abroad. So thank you, Dr. Min, for the question. Please, team, the residents, you may answer and clarify Dr. Min question. How do you diagnose the mucormycosis in the first case, in the second case? It's only from the mycology result examination, right? So please answer question from Dr. Min.
Yes, thank you, Dr. Min Huang, for the comments and also the questions. So we met these patients in the outpatient clinic, and then we found during the nasal endoscopy evaluation, we found that there is whitish hyphae appearance on her left nasal cavity. Therefore, we perform the parasitology evaluation to evaluate the fungal, the type of the fungal that invades the left nasal cavity. And during the evaluation in the outpatient clinic, a week after that, we found out that the results of the parasitology evaluation from the left nasal cavity was rhizopus that indicates the mucormycosis. Therefore, we directly admit the patient to the emergency room and perform the emergency surgery for the patient to evaluate the condition of the patients, and the intraoperative intraoperative tissue that we have taken out during the surgery was also sent to the parasitology evaluation, and also for the histopathological evaluation. But until now, the results is not come out yet.
Oh, okay.
What
Thank
about
you.
direct examination? Excuse me, Dr. Min. What about direct examination from the surgical specimen for the mycology? Is still not available? Aris or Diar or anyone could answer.
Okay,
Give
pardon me.
a further explanation.
Okay, pardon me, Dr. Dani, for the intraoperative the findings from this patient that we are still waiting for the result, and also basically from this that's what we would like to discuss with Dr. Min Ho also. So based on the intraoperative findings and also from the initial assessment from this patient, as we could see that we cannot see the black scar yet in this patient in the both of the side of this in this patients, that although that we have found in the left side that there's positive the rhizopus species in these patients, that we could not see that any classic characteristic sign that we may conclude that this is the mucormycosis or the invasive fungal rhinosinusitis in these patients. But yeah, from that's what already are explained before, that in this patient that we already take the sample from this patient that maybe about 3 to 5 days prior to the admission, that we admit the patients to the emergency department that the patient has the rhizopus infection in these patients. But yeah, unfortunately, that the result from these patients, that is it the true the rhizopus patients or not, that we still may need more time, and also that from that we can conclude that in this patient that we cannot take the conclusion that this patient has already the invasive fungal infections, that we may still be waiting for the histopathological examination from this patient. So in this patient that we are still waiting for the further examination. But in the first examination for this patient, that yeah, the patient that has the rhizopus infection in this patient. But from the intraoperative findings, that the result yet to be confirmed. Thank you very much, doctor.
Okay, please, Min, your opinion needed.
Yes, because when I approach the patient, first thing, like the resident say, you need to talk and have a good history about underlying disease, and both of the patient had the DB, and also the second one had the DB type 2 with uncontrolled condition. And then you find the mucormycosis. But at that time, I'm not sure you only do the culture or you did the biopsy at the first time, and then you identify the mucormycosis. Because when you see mucormycosis, you need to be careful because it's more severe in the patient in the severe condition compared to if the patient had the aspergillus. Aspergillus. So with the mucormycosis, and then you need to think about the invasive fungal sinusitis. But because you don't have the enough finding in the first, because you only do culture, maybe confirm to me, you only do the culture at the first, or you detect the biopsy at the OPD in the outpatient clinic. You only do the culture and you see the mucormycosis, or you take the biopsy to see the hyphae in the basal lamina, because you need to define it is invasive or not invasive. And if the patient got the invasive fungal sinusitis, you need to bring the patient to the theater like what you do are right, and then you need to deprive everything until you see the fresh matching. And the second thing I would like to add is about the finding intraoperative, because you know that invasive fungal sinusitis have very specific finding, like the yellow butter discharge, and also margin or any necrosis finding intraoperative. But in this patient, I don't have that the finding, so I a little bit confused a little bit. But for all of the, based on the her symptom and also her condition, I think your treatment is right. But I really want to know the patient got the invasive fungal sinusitis before the surgery or not, because you take around 1 week before you bring them to the operation. That's my question for the second case. And for the fungal finding in the lab, spinosynate, you can see on the CT scan, so it like the same problem, another concomitant problem on the CT scan. You see the opacification very clearly, so no doubt about it. Yeah, that's for second case, and you need the right treatment about the antifungal treatment for this patient. May I have for the first question, for the first patient, one thing, now the OD is not improved, right? So what do you consult with the ophthalmologist and the neurologist in the case the vision is not improved? May I ask the resident and how you treat the patient?
Yeah, please. So if, dear and Aris, do you understand Dr. Min questions? So if the visual acuity is not improved, what will you do with this patient? What your plan with the ophthalmology? Is it right, Min?
Yes,
Yeah.
proceed.
Especially for the first patient with the visual acuity 1/300, and but for the second case, the right side was already accentuated, right?
Yes,
The
already.
right side, but the fungal was found in the left side, but the left side visual acuity is good. Is it right? So what's your plan for the first and the second case? Because in the second case, the left side has the fungal infection. But what about the visual acuity? How you preserve the visual acuity? And what about and also for the first case? Please, you may share your opinion. This is not about right or wrong, yeah, Arif, dear. It's okay to share your opinion based your understanding, so we can evaluate level of your understanding. If Delia and Lisa also want to share your opinion, please, you can. You are most welcome. Yeah, especially to Delia, because this is these two cases will become your case presentation. Okay, Delia, you may share your opinion to Dr. Min.
Okay, thank you, doctor. For the second patients, I met this patient from the outpatient clinic. The tissues for histopathology and also the parasitology we take from the crust and the meatus in the middle meatus, and we also found the hype when the first time she came to the outpatient clinic, and we take from the middle meatus too, and the from the hype we found at the left nostril, and the crust we found at the right nostril from the second patients. And I think we also do consult to the ophthalmologist and the neurologist after the admission, and the ophthalmologist is prepare or plan for the accentuations, because there is no light perceptions on the right eye, and the left eye still good. And we also next maybe we collaborate with the eye department or ophthalmologist department to also the next care of these patients, because we still waiting for the histopathology finding. Okay.
Yeah. Dr. Min, do you have any other shared opinion and the clarification, please? Please unmute yourself.
Oh, okay. Actually, I like the two cases and also most of the explanation from the resident. For the second case, because in July, when I was there, we did a study that we can do the retroborough amphotericin B for the case for the invasive fungal sinusitis. So I'm just want to share the experience. Like in the case, the patient had the problem with the vision, and the patient also have the invasive fungal rhinosinusitis. You can do the retroborough injection of amphotericin B. Yes. So you may try it in the future. That they already report like actually not very high evidence to prove the patient will not improve the vision after the injection. But in our case series, we found the compared to the control group. If you inject the amphotericin B, but the patient got the invasive fungal sinusitis to the orbital, the patient might get the benefit from it. So that's what I want to know. That's why I also concerned about the second case. Actually, for the first case, it's okay. But the second case, you are thinking about the invasive fungal sinusitis. You need to do different treatment for the patient. But in the case, you already did the orbital acceleration, so it's it's okay. Yeah.
Yeah, I think yeah, it's very interesting. So we will stay away for the histopathological examination.
Yes. Yes.
So we have here Dr. Susal from Brunei. Dr. Susal, please give comments to residents' case presentation. It's very honored to have you both in our residents teaching methodology. Please, Dr. Susal.
Hi, good morning. Assalamualaikum. Thank you. Thank you for inviting me. Yeah, it's a very interesting case, considering how big your population is. I know we had a case like this similar, but you may think that we Brunei are so small, that accessibility to healthcare is essentially quite easy, but we do have our own problems, and but our case is small. But we had a case before similar to this, and I agree with Prof. Min that the difference between aspergillus as well as mucormycosis need to be defined clearly, because the treatment and the aggressiveness of that pathology are two different cases. And sometimes maybe, maybe worth giving some time to allow the histopathology results to come back, or maybe just kindly sort of give a gentle nudge to your histopathologist to give it a priority to your case to see whether they could look into the specimen quicker and not just be part of the queue of the ample of work that they have to do. Because yes, there is this about time, balance of time, trying to intervene it as soon as possible. Maybe you can consider that. Yeah, the treatment is different. It needs a multidisciplinary input. Over here in Brunei, we get our infectious disease consultant to be involved as well. And in our case, we Bruneians are a bit very reluctant to go for any form of surgery. So that's why we're not as aggressive surgically compared to maybe you guys. So, but we have treated them with medications, and it was quite a long course of medications. And it was difficult as well for us to ensure compliance, because it was more than 6 weeks course of antibiotics or antifungal, sorry. And for them to keep regularly coming to our clinic so that we can do toileting of the nose in the clinic. So it was a difficult journey. And we had that lady whom we had similar problem. She, for any second or third surgery, even the first surgery, we had problems trying to convince her. But for the second and third, I'm not sure how acceptable she would be, or agreeable for her to have the surgery. So the only way that we could do is for her to ensure that she is compliant with her toileting at home, and she comes as often as possible to our clinic to continue the debridement in the clinic. She has pain, so we didn't go through orbital exenteration. We gave her gabapentin, which luckily, and tramadol, which luckily subdue her symptoms to bearable for her. So we didn't go through the exenteration stage at all with her. And eventually, with a lot of patience, a lot of drilling, a lot of advice, a lot of coaxing with the patient, we managed to get through, and she finally settled. So I know it's not easy for residents to look after this kind of complex cases, and especially it takes a long time of dedication and passion to look after them. So I congratulate your residents for hard work. Congratulations.
Yeah, actually, to understand the cases because it's very complex cases, and they
Very-
try their best. They try, they practice, and make a rehearsal with so many consultants before presenting this. And
Yeah.
yeah, we are proud of you, all of you,
Yeah.
with your works.
It's
Yeah,
not
it is.
easy. It's not easy.
Yeah, it is about the process, I think, not the outcome. So
Yeah.
that
Yeah.
the outcome is if you do this kind of process, you will be in the future like Dr. Min or Dr. Susal. Yeah, okay, that's a good role model from our Asian
Well
country.
done. Well done.
Yeah, thank you so much. So once again, Aris, Diar, Delia, Disa, and Yogi, thank you for presenting these very complex, complicated cases. Actually, you don't have only 2 cases, but it's still 3 cases because 3 sinuses and all show the different clinical manifestations. So thank you so much. Now we'll move to the second part of the interhospital meeting between Jakarta, Bangkok, and Hue, Vietnam, and Brunei. Please, we welcome to very honorable Dr. Min Huang to present the case. Please, Dr. Min.
Okay, thank you, Professor Danny. May I share my slide?
Yeah, please.
Okay, can you see my slide now?
Yeah.
Okay. So today I have a talk about the central compartment atopic disease, and we call it is a distinct TS2 phenotype of chronic rhinosinusitis. So first of all, I would like to say the thank of all of my teachers, my research team in Bangkok, and my mentor, Professor Konkiat Sinisbong. If you know the names or the terms CCAD has been proposed the first time in 2017, it means it's quite new. However, if we take a look back on our textbook in the past, in the early of 2000s, Professor Varale Lund, she wrote the book, and take a look on its cover. There is a picture showing the fully opacification at the central part of the nose. And at that time, we don't know about the CCAD, but Professor Varelun had the name for this finding, and she called it the black halo, with the central opacification of the middle terminae and the septum with the very clear and have very clear, healthy maxillary and the other laterally. And after that, in 2017, Professor Del Gaudio had first time reported to the world, and they decide to have the name CCAD. It means Central Compartment Atopic Disease. So before we go into detail, let's take a back and to know about the classification of the primary CS. I believe that here most of you guys know about the classification in EPOT 2020 that we will define into 3 types: type 1, type 2, and type 3. And you know that for the type 1, the dominant neutrophil characterized with the CI without nasal polyp, and it trigger intracellular pathogen like the microviruses. And for the type 2 CI, it is consequent by the helminth infection, allergy, characterized with the asthma, allergy, goblet hyperplasia, mucus production, and most of the patient got the CI with nasal polyp, high eosinophil, and the IgE production. And for the type 3, it will be the characterized by the extracellular bacteria, fungi, and CIAC. And after that, the EPOD 2000, the steering group of the EPOD 2020 defined characterized into the non-type 2 and type 2 CIACs. And if you look on this very beautiful picture, we know that we can define by now we characterize the CIAC by the endotype dominant. And after we define at the endotype dominant, we will have the example of phenotype. And CCAD located in the phenotype CIAC type 2 with the diffuse finding on the CT scan. Again, you will see this picture in many presentations from many presenters before, because you know that at that time we don't know anything much about the inflammatory mechanism in the developing CIAC. So we adapt the phenotype of the asthma into the phenotypes of the chronic rhinosinusitis, and usually we have three phenotype about the allergy, which happen in very early of the childhood. The second one is the eosinophilic chronic rhinosinusitis, and the non-eosinophilic chronic rhinosinusitis. And it will happen in different of your life. For the childhood and young adult assets, most of the patients had the rhinitis and asthma symptom, and it more related to the common allergen exposure, and it's only simple IgE mediated. For the adult onset, the patient will have the sinusitis, maybe polyp and the asthma, and commonly it is eosinophil, and it was driven by the innate lymphocyte, and it caused a local response to the epithelial signaling. Sorry. And for the late adult, it will clinical feature with the obesity, more for a female dominant, and the patient with the CIAC without nasal polyp, low IgE, and steroid insensitive. So if you know about the phenotype and if you know about the history of the patient, when the patient develop the symptom, if you have the good history, you will know the potential phenotype of your of the CIAC patient. And the next question is, what is CCAD? Before the EPOD 2020, we don't have the enough sufficient strong evidence to show the relationship between the allergic rhinitis and the chronic rhinosinusitis. But in EPOD 2020, the steering group proposed again the term CCAD, aka central compartment atopic disease, and it's either new variant of the CIAC with nasal polyp, and characterized by the edema and polypoid chain in the central sinonasal cavity, and is strong associated again with the inhalant allergen, and it will affect the most areas is the more common area is either middle turbinate, superior turbinate, and posterior superior nasal septum. So this is the history of the CCAD. For my talk today, we will review all about the current knowledge to find what is the gap of the missing knowledge, and also that what is the gap for the room for the research in the future. However, we need to have the milestone about the CCAD, and the first milestone is 2017, when the Del Gaudio and the research group first time present the term central compartment atopic disease to the world, and most of the paper after this work, we use the definition in this paper for the definition of the CCAD. And the second milestone is in 2019, when the Professor Grayson and Professor Richard Harvey, they described the clinical relevant phenotype of the chronic sinusitis, and they show the different in terms of the clinical finding, radiological finding, and also the treatment. And the last one, because There is a time when we lack the information about the biomarker and the inflammatory biomarker. We don't know what is the difference between the inflammatory biomarker between the CCAD and other subtype of the CIAD with nasal polyp. And in 2023, it's published, I think last month, Dr. Ruben and the team, they described the inflammatory characteristic of the central compartment atopic disease. So this is the three key milestones that you need to know about the CCAD. So in 2014, Professor White and the team, they conducted a study to find the association between the polypoid edema in the middle turbinate and the allergic rhinitis. And this is the case series, and they enrolled 25 patients with the allergic rhinitis symptom. And the endoscopic found the isolated middle turbinate polyp, as you see on the screen. Here, and here, and here. And the patient had the CT scan to confirm the no polyp extend beyond the middle turbinate. After that, they ordered the patient to do the skin prick test, and there are 16 patients agreed to join to do the skin prick test. And surprisingly, 16 patients, 100% found allergic test positive. What is the meaning of the finding? So it means when you see the patient with a middle turbinate polypoid, you may consider to do the allergy testing, or you may consider about the patient got the allergic rhinitis. And why it happened in the middle turbinate? Because if you know the airflow occur primarily between the inferior turbinate and the middle turbinate. So the middle turbinate it plays a role like the filter for minimal allergen irritant from reaching the sinus and nasopharynx. And this is the one of the first barricades when the allergen go to the nose, penetrate to the nose. That's why it got the problem, and it got the polypoid edema. And in 2017, Professor Hamilton, they tried to describe the different kind of the middle turbinate edema, and they will gradient at the normal here. They had the focal only one part of the head, one part in the head of the middle turbinate, or multifocal here, or diffuse and the polypoid middle turbinate. And they try to find the diagnostic accuracy of this kind of the characterize of the middle turbinate edema in the diagnosis of the allergic rhinitis. And they found it both multifocal edema and diffuse edema of the middle of the middle turbinate show very high specificity and have very high predict positive value. So they conclude the middle turbinate test may be specific with a good predict positive value. However, it had not a good sensitivity test for allergic rhinitis. And it may be a potential marker, and we need more study in the future to use it as the marker, as the surrogate marker for inhaled allergen, because we know it's both simple and reliable. And in 2022, the group in Sydney, including Professor Richard Harvey, they do a systematic review and meta-analysis, try to find the feature of inhaled allergy on the nasal endoscopy. They try to find if are there any finding based on only with the nasal endoscopy can predict the patient got the atopic disease in this case inhaled allergy. And they found that there are two findings that may be very consistent, and you may use them as the marker to identify the patient or prediction of the patient with allergic rhinitis. The first one is the diffuse polypoid edema, as you see on the rock cup in the left. It had the sensitivity is around 60% and it's very high specificity is around 90%. The second one is the watery secretion in the nose, and it also can be a useful adjunct for the diagnosis of the allergic rhinitis. Oops, sorry. So in the lab video, we found that if you use the anterior rhinoscopy and you see the clear fluid watery discharge like this one, you might consider the patient got the allergic rhinitis. And the second one, when you use the endoscopy, I recommend you use the nasal endoscopy to examine the middle turbinate. And if you see the jelly line middle turbinate, you might consider the patient maybe had the allergic rhinitis. And why I talk a lot about the relationship between the polypoid middle turbinate and the allergic rhinitis, because it's also characterized of the CCAD when the patient got a polypoid edema at the middle turbinate and the septum superior posterior septum and also the superior turbinate. And if after the decongestion, this is the fourth finding you may take in your mind, that it may be indicator of the allergic rhinitis. The first one is the polypoid middle turbinate. This is the edema in the middle turbinate. This is the polypoid middle turbinate. The third one is the watery secretion, and the last one is the inferior turbinate hypertrophy. If you see this for finding after you do the decongestion, you may consider the patient got the allergic rhinitis. So the next question is, if your patient had the polypoid chain in the middle turbinate, it is had different from the paranasal sinus polyposis. And we know that for the paranasal sinus polyposis, most of the polyp located at the middle meatus, not the middle turbinate. And for the polypoid chain of the middle turbinate, most of the finding you see when you do the nasal endoscopy is in the head of the middle turbinate, as you see on the screen. And surprisingly, when we compare the two groups, the first group is the paranasal sinus polyposis, and the second group is polypoid in the middle turbinate. The patient with the polypoid at the middle turbinate had higher chance got the allergic rhinitis compared to the one having the paranasal sinus polyposis. And also the patient with the paranasal sinus polyposis had the worse quality of life than the patient with the polypoid related to the middle turbinate. So what is the recommendation here? You should do the nasal endoscopy, not only the anterior rhinoscopy, because you need to separate from the paranasal sinus polyposis from the polypoid middle turbinate for the prompt treatment. And the polypoid chain of the middle turbinate associates with the allergic rhinitis, not the chronic rhinosinusitis. And as I mentioned at the beginning of the talk, in 2017, Professor Del Gaudio and the team, they defined the term CCAD, and it's either polypoid edema friendly polyp at the middle turbinate, superior turbinate, and posterior superior septum. And they conclude the CCAD is a new variant of the CIS require the allergy management at the core component. Recommend the And this is one of very few phenotypes you need to do the allergy immunotherapy after operation. And this is the endoscopy of the CCAD. As you see, there are the polypoid and polyp in the middle turbinate nasal septum, and also in this case, it's also at the uncinate process. Why? Because when the middle turbinate is narrow, the aero allergen will go here to the airflow tract and it will hit to the uncinate process, and it's also cause the polypoid at that anatomy structure. And in the figure B and C, you can see the polypoid at the nasal septum here and the polypoid at the middle turbinate here. So this is the very it is the specific finding when you do the endoscopy with the CCAD and the middle turbinate polyp. And in that case series, about a case series of 15 patients, all of the patients complained about the nasal obstruction, and all of the patients had the positive with the skin prick test. Again, there are the relationship between the CCAD and allergic rhinitis. And the next one, you have to define the stage about the CCAD, and Professor Gaudio and the team, they define the CCAD into the 3 stages: early stage, next stage, and late stage. And in the early stage, if the patient come to your OPD, you only after you do the nasal endoscopy, you find the middle turbinate polypoid edema. And if the patient is untreated or treated insufficiently, it will go into the next day with the polypoid edema at the superior turbinate or posterior superior nasal septum. And in the late stage, it will further progress to the secondary sinus obstruction. It's not only at the central anymore, but it will have the lateral sinus involvement. That's we call medial to lateral progression. So it is the finding at the early stage. As you see, they had the polypoid edema at the central of the nose. And when the patient is insufficiently treated, the disease will go laterally. It will affect to the maxillary sinus here with the obstruction at the middle method in the maxillary ostium and the OMC occlusion. And one finding in the CCAD is mean when you do the surgery, when you go into the small mucosa, as you see on the figure D, most of the findings show that there is a healthy mucosa at the ethmoid area. That means the CCAD is only characterized with the polypoid edema in the central component. They not go further into posteriorly or maybe laterally. So with the endoscopic finding summary, the CCAD had a watery polypoid chain in the middle and superior turbinate and posterior nasal septum. And in the radiographic finding, you find the central sinus dominant with the peripheral clearing. Remember, you only see the problem at the central of the node. However, the peripheral, the laterally, you osmo clear. So this is the radiological characteristics of the CCAD. As you see, most of the disease located on the center of the node, with all the other sinus are clear. And once again, there is another interesting finding that you will differentiate from the CCAD and from other diffuse CRS like the eosinophilic rhinosinusitis. It means if the patient got the problem, the soft tissue thickening only at the central portion of the nose and also at the floor of the nose, but never reach the lateral and superior limit of the lateral of the sinuses. As you see here, the lateral and the superior, the roof are always clear. And this is the difference between the ECRS and the CCAD. For the eosinophilic chronic rhinosinusitis, it is the diffuse disease with the osteoneogenesis, and the disease we had the diffuse mucosa involved in all of the massive sinus. However, in CCAD, the lesion only located at the floor of the disease and never reached the roof and the lateral wall of the sinus. So this is a very important finding that when you read the CT scan, you can define what is the ECS and what is the CCAD. And remember, on-part sinuses must be central limited. In here, when we do the coronal view and also sagittal view, you see the disease only at the central, not anterior, not posterior, not lateral. Here, most of the patient got the centrally limit for the sinus located in anteriorly, posteriorly is almost clear compared to the diffuse disease on the figure C and figure D. And as I mentioned in 2019, Professor Grayson defined and also characterized the finding of the CCAD based on the clinical presentation, endoscopy, and radiology. And the CCAD, as I mentioned for the phenotype of CAD before, it happened most of the patient in the young onset. At a teenager to around 20, the patient got the rhinitis symptom like the symptom of allergic rhinitis. And there are no problem with the smell. And the patient may have the other atopic disease like the childhood asthma or the conjunctival symptom dermatitis. For the endoscopy, you can find the middle turbinate edema, polypoid from turbinate and septum, no thick mucin, no sinus mucosa on surgery. And about the radiology, we can find the central thickening of the septum and turbinate, peripheral, always clear. The mucus trapping only in the sinuses and normal anterolateral sinus mucosa, what we call the black halo. And how about the histopathology? What is the difference from CCAD to other disease like the ECRS and the non-ECRS? So for the CCAD, when you take the biopsy, you can find the elevated tissue eosinophilia, often without the activation, no eosinophil aggregate, and no charcoal-laden crystal, which is very unique finding of the ECRS. And they had no serum eosinophil and the elevated total, and the patient got the elevated total and specific IgE. And the patient, when you do the skin prick test, allergy test, they had the positive to the skin prick test or serum specific IgE, and most often it's the monoallergen, not polyallergen. And the treatment for the CCAD had the main role of the allergen-directed immunotherapy. The patient need the operation to reduce the drainage and also the blockage of the nose for the airflow, and also the topical corticosteroid spray or irrigation. But you need to do the surgery before you do the immunotherapy based on our experience. And in the case the patient had the difficult to treat, you might thinking about omalizumab because there are some study show the evidence omalizumab can use to treat the recalcitrant allergic rhinitis. And once again, this is a summary the different finding with the T2 allergic rhinitis, what we call the CCAD here. You can see the black halo side, the edema, polypoid edema at the middle turbinate and the eosinophilic in the histology. However, with the patient with tier 2 eosinophilic CID with nasal polyp, they had the diffuse disease on the CT scan and had the osteoneogenesis and also the charcoal-laden with the black arrow and also the hyphae on the indicate the patient had the allergic fungal sinusitis. And for the T1 CID without nasal polyp, we don't see that kind of a problem because the polyp is not located in the nasal cavity. So the next question is CCD have any relationship to the asthma? And we found that in the Muscat 2020, they described a case series and they found that the prevalence in AERD is 100%. However, the prevalence of asthma in CCAD only less than 20%. So they conclude that the prevalence of the asthma in AERD are significantly higher than the AFRS, CCAD, and CI with nasal polyp, non other specific type. But CCAD had the high relationship with the allergy. Here is mean allergic rhinitis, and the prevalence is around 97%. So we have another disease, what we call respiratory epithelial adenomatoid hamartoma. I think you may not familiar with the term, but it is the benign lesion of the sinonasal tract that commonly located within the central compartment. It's like CCAD, and it had the granular proliferation of the respiratory surface. Epithelium ingrow into the deeper mucosal layer, and we categorize it as a tumor had the reactive hyperplastic process of the chronic inflammation or damaged mucosa. And we may misdiagnose diagnosis with the aggressive neoplasm, but there is no aggressive behavior or malignant potential. So this is the endoscopic finding of the hamartoma. Here is also located at the superior meatus at the olfactory cleft, and most of at the superior nasal septum and olfactory cleft, and it frequently coexistent with the sinonasal inflammatory condition. And about the treatment, there are no evidence-based treatment recommendation. And you can see here there are the lesion at the olfactory cleft as you see on the endoscopic finding. And the next is anything different between the ECI and the CCAD. And we found that in the case of the CCAD, the patient had the onset of the symptom, and the age of the patient had the lower compared to the ECI, and the patient not had any biologic at the time of surgery, or however, the CCAD received more sublingual immunotherapy at the time of surgery in this series. And about the inflammatory condition, the ECI had the severe condition more than CCAD. And when we compare the eotaxin 3, the eosinophilic chronic rhinosinusitis had more eotaxin 3 compared to the CCAD, suggesting a greater degree of eosinophil stimulation and chemotaxis. And that's why the patient with the ECI usually have the more complaint about the downgrade in quality of life compared to the CCAD. So next is what is the difference between the CCAD versus different subtype of the nasal polyp? As you see on the screen, the CCAD different in terms about the asthma, about the allergic rhinitis, about the prior surgery, about the CT score, about the eosinophil in the histopathology compared to the AERD, allergic fungal rhinosinusitis, or the subtype of the CR with nasal polyp. So it should be a distinct TS2 phenotype of CR with nasal polyp. And in 2023, there are one study show that the CCAD had the lower TS2 inflammatory marker regarding the eotaxin, interferon gamma, interleukin 6, interleukin A compared to the AERD, allergic fungal rhinosinusitis, and other subtype of the CR with nasal polyp that we cannot define the definition. And it also lower the interleukin 5 and interleukin 13 compared to AERD and AFR. So once again, it can, now we have the evidence show that the CCAD had the distinct characteristic in terms of the clinical finding and also the laboratory finding regarding the inflammatory biomarker with the low level of the Th2 biomarker compared to other Th2 phenotype. However, it also raised the question that CCAD, we call it the CCAD. However, Professor Glenys Scardin, she write a letter to the editor to rename the name CCAD to PPAR. PPAR, what does it mean? It's either polypoid allergic rhinitis because Professor Glenys Scardin think that the CCAD is just a phenotype of the allergic rhinitis, which I disagree because chronic rhinosinusitis is different from the allergic rhinitis. So we treat the patient with CCAD as we treat with the CIAD, not like the way we treat with the allergic rhinitis. We need to do operation in case the patient had a polypoid and cannot controlled by with the appropriate medical treatment. You need to bring the patient with the CCAD to the operation to deprive the polypoid at the middle turbinate to open the drainage and also the airflow to enlarge the airflow pathway. And after that, you may consider the patient with the immunotherapy later. And if we treat both allergic rhinitis and CIAD in the same way, we may use the intranasal corticosteroid because with the Cochrane review and a lot of systematic review, and meta-analysis, we know that both allergic rhinitis and the chronic rhinosinusitis had received the same benefit from the intranasal corticosteroid. However, for the immunotherapy, it means based on our experience in Sydney, we recommend the immunotherapy for the CCAD after we do the operation. About the antihistamine, we don't recommend it. And how about the post-operative outcome of the CCAD compared to different subtype of the CIAD with nasal polyp? And surprisingly, with the patient with the CCAD, the patient had a better post-operative outcome compared to other subtype of the CIAD with nasal polyp, like AERD, allergic fungal rhinosinusitis, and other undefined CIAD with nasal polyp subtype. And the prevalence of the polyp recurrent and the revision ESS after the primary surgical intervention in the CCAD is very low compared to other subtype, as you see on the screen. And it's suggesting durable benefit from ESS and post-operative medical therapy in CCAD patient. And again, we had on the figure, only 3 patients had the recurrence at the time point 6 to 12 months. 1 patient had recur after 4 years, and 1 patient had the recurrent after 5 years after the first operation. How about the total oral antibiotic and oral steroid uses? When we compare the CCAD with all of the CIAD with nasal polyp, the CCAD patient had the better outcome, post-operative outcome in terms of the antibiotic and steroid compared to the CIAD with nasal polyp. However, when we compare it individually up in the post-hoc analysis, it lower, but it not reach the statistically significant. So in conclusion, now we know that CCAD is either distinct Th2 phenotype of chronic rhinosinusitis strong associated with allergy. When you do this, the clinical examination, you can find the edematous polypoid chain in the central sinonasal cavity associated with the inhalant allergy. And the endoscopic and CT combined with the CT finding will be the golden standard for diagnose the CCAD, which is located at the middle turbinate, superior turbinate, or posterior superior nasal septum, and less cytokine level than other Th2 subtype of CIAD with nasal polyp. If CCAD, the patient with the CCAD left with untreated, it will have progressed to the secondary sinus outflow obstruction, medial to lateral progression, with the lateral center clearing and the black halocyle. And for the treatment, you need at the treatment for the chronic rhinosinusitis, we need operation intranasal corticosteroid and with the control allergy, and we suggest immunotherapy after the operation. So thank you for your listening.
Thank you, Dr. Min, for your lecture. Probably the audience will ask a question. We still have 5 minutes before we end the meeting. Please, if anyone want to ask question. Okay. And the residents, you want to ask question to Dr. Min about the CCAD, and then you know that it is different with the TH2, the eosinophilic or TH2 CRS, because it's the different endotyping. And also the phenotyping, probably in the first treatment of the patient. I mean, if the patient comes and we can see that it's a halo sign, and then we can classify it as the CCAD. Any question? Yes.
Good morning. This is Mr. Min Huang. Dr. Min Huang, I think I have a question. In this case, how long that we should have to wait to do the conservative treatment before decided to do surgery? Because as we know that one of the treatment of this patient is to control the allergy by giving the corticosteroid intranasal, maybe with the using conservative treatment as the allergic rhinitis itself, it can control the disease, and we don't have to do the surgery. Thank you, Dr. Min Huang.
Yeah.
Okay, may I answer the question from the resident?
Yeah. That's the resident from Disa.
Okay.
She asked you how long that we have to give the conservative treatment to the CCAD patients, and then the decision of the surgery is only given the antibiotic or the intranasal steroid, or we should have give also the antihistamine. Please. Yeah.
Okay. Thank you for your interesting question. As I mentioned, we need to consider the CCAD at the CIAT condition. So for CIAT condition, usually you have the medical treatment for at least 3 to 6 weeks until you will evaluate the symptom again, and then you will put your patient into the well-controlled, partly controlled, or uncontrolled. If you know, in the EPOR 2020, we define the criteria to define what is the uncontrolled, what is the partially controlled, and what is the well-controlled. If the patient is uncontrolled or partly controlled with the appropriate medical treatment, in this case, it is the intranasal corticosteroid. I don't give them too many antihistamine for the CCAD. Most of the time, I use the corticosteroid with the nasal spray, and sometimes it had the short course of the oral corticosteroid, and also saline irrigation if the patient not completely or not improve completely. I will continue until 3 to 6 weeks, and after that I will re-evaluate again. And if on the finding on the endoscopy there are still the same problem, I will suggest the patient and consult them to go to the theater to deprive the polypoid at the in the middle turbinate and also sometimes at the uncinate process. Yes, that's my step of the treatment for the CCAD patient. I do immunotherapy in Thailand after the patient got the operation, but in Vietnam now in my institute I don't have the immunotherapy, so I keep the appropriate medical treatment after I do the operation. However, if I have immunotherapy, I will suggest the patient to do the immunotherapy after the surgery. You know, there are only two subtype of the TS2 CIS with nasal polyp that that the patient can get the benefit from the immunotherapy. The first one is the CCAD, central compartment atopic disease, because it is atopic disease related. The second one is the allergic fungal rhinosinusitis. That is the only two subtype of TS2 that you may use the immunotherapy after the surgery.
Okay. So a question from me to need your clarification. Determine we cannot perform the CT scan to have the distinct characteristic of the CCAD at the first time. This is you mentioned about black halo sign, because CT scan usually perform after we give the appropriate medical treatment. So in your experience, is there any changes if we give the presume this is CCAD, and then we give the appropriate and suitable medical treatment? Can we have the clear CT scan after that medication? Usually we give the medication for 6 weeks, but because of the long QA of the surgery, then we give the patient up until 12 weeks, sometimes or more. Please, your clarification is appreciated.
Yeah, thank you, Professor Danny. It's very interesting question, and we have the same problem in every hospital. Like had long queue operation, so sometimes we cannot. So the first thing is about we should do the endoscopy finding first, and this is like the gold standard. And then after you do the endoscopy, you find the polypoid only located at the middle turbinate, not at the middle meatus. That is the different things. If you see the polyp at the middle meatus, it's not like the CCAD, or maybe at the late stage of the CCAD compared to the CCAD at the very early stage, because the CCAD in the early stage only happen in the young adult, young people, not very old people, like 40 or 50%, 40 or 50 years old patient. Usually they have like ECI or other kind of problem, and it's secondary to the CCE in very young early age. So that is the history is very important. The second one, as I mentioned, is about the endoscopic finding. If only polypoid at the middle turbinate, not at the middle meatus, so it is CCAD. But if you find the polypoid at the middle meatus, you may consider in other things, not CCAD. That is the characteristic of the endoscopy finding. And after, I also do the endoscopy at the first time, and I will do the CT scan evaluate after the patient fell with the medical therapy. I don't do at the same time with my first initial my initial treatment. And if I found the black halocyte, I will define the patient the CCAD. That's the thing that happened with the literature right now. Like even there are more study about the CCAD, but the diagnostic criteria are different. Some study they use the endoscopy and CT scan at the combination of the diagnostic treatment. But in some study, they just use the endoscopy or CT scan at the diagnostic criteria. So it's still like the heterogeneity in terms of the diagnostic criteria. However, if you read most of the paper of the CCAD right now, we agree like endoscopic finding with the polypoid at the middle turbinate, superior turbinate, and septum, we can call it CCAD. And after that, if you have more finding feature on the CT scan, we can give more evidence that your patient got the CCAD.
Yeah, it is interesting because I just remember several patients with this kind of phenotyping, and then because we start with the patient's quality, because patients is diagnosed as allergic rhinitis, and then we quantify and make a quantification of the allergic rhinitis. And then we know that this patient have also the sleep disordered breathing. And for us, it is interesting that in some patients, not all patients, because we're still confused about the CCAD. The one of my patients, because I looked at it's a polyp is in the middle turbinate, and I give the medication, and then after this we check also for the sleep disorder breathing, and then we perform the surgery for the OSA because the problem is the phallus in the complete concentric collapse, and then suddenly all the polyps is disappeared. So, but again, if the patient lost to perform, because still we don't have the immunotherapy to do the nasal washing, or do not have the supply for the intranasal steroid, then the polyps come back. So I think we have to think more thorough, yeah. And thank you, thorough intervention. So look the patient holistically. So in our setting, probably that's the CCAD patients, probably, because I think at the first time that CCAD is only for diagnosed by the CT scan. And of course, with the CT scan, we cannot have that kind of phenotype of CT scan, because in all of patients it's like clear after the medication. But one or two cases, and then I realized, oh, this is actually CCAD, because after long treatment, still the problem in the central compartment.
Yes.
Yeah, and then yeah, I believe that this also. But as in the last patient, we diagnosed as the CCAD because after medication, and we can see that the halo, the black halo sign, and also only in the central compartment. And we evaluate with dyes, and very fortunate, the patient do not show any complete concentric collapse. So we think that we have to perform. That's Pak Song Chin. Remember, Pak Song Chin have a central compartment CCC at the phallus, right? And we will do the next step is the UP3 for this case, to control the inflammation from other pathways, in my opinion, because we don't have the immunotherapy. We just rely on the nasal irrigation,
Agree.
steroid therapy, and that's very interesting, I think.
Yeah.
Thank you so much to clarify and
Yeah.
make my understanding deeper because of your explanation, Dr. Min.
Yeah.
Thank you so much. Yeah. Hopefully, because this is a very benefits meeting to our education system, Dr. Min, in the University of Indonesia. And thank you for everyone join this from other centers. Hopefully, you can find your own counterparts, yeah, to find someone abroad to train the residents to practice English, and then to face the foreign teaching faculty. I mean, the guest teaching faculty from abroad. So thank you so much, Dr. Min, for your coming to the meeting. as a regular meeting every 6 weeks, and we'll have probably in the next meeting, Dr. Susal share the lecture, and then we are happy to meet another group of our residents to join with this meeting. Thank you so much. And with this, I would like to once again good luck and good day for
Your
today. Thank you.
tell
All the best to you, Dr. Susal and Dr. Min.
Thank you so
Bye.
much, Professor Danny. I
Yeah, thank
always
you.
delight to see your recent video all the time, and
Yeah.
I love to stay here and have a talk and explain or share our experience together. It's very good. Yeah.
Yeah. Why not? Yeah, and we wait also for your residents to share their cases.
Yes. I am on the process because right now in Vietnam we need to work very early, and if the resident go to the conference, sometimes we had to apply the permission. So I arrange everything, and I also prepare the case for them so they can present it in the future. I will
Yeah,
send you the message.
Yeah, I think once in a year is okay because we have what is it, eight times meeting, right?
Yeah.
For each semester. So probably once from Vietnam, it will be okay in one semester or in 1 year. Okay, thank you so much, Dr. Min. So with this, I will close this meeting. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Waalaikumsalam.
wabarakatuh.